Hello, everyone. I hope everyone is staying safe during this pandemic. My name is Asim Syed. I'm a second year internal medicine resident at Florida Atlantic University. And without further ado, let's get into the case report. The title of my case report is Too Sweet to Just Be DKA, a golden ticket to a cardiac cath. So we have a 53-year-old male with a significant medical history for diabetes, mellitus type 2, hypertension, gout, gastroesophageal reflux disease, and 44-pack year smoking history, who presented with 2 days of abdominal pain, nausea, and 15 plus episodes of emesis, which eventually became bloody. His vitals showed hypertension at 140 over 90 and tachycardia at 138 beats per minute. Physical exam showed dry mucous membranes with poor dentition. The patient denied any active chest pain, shortness of breath, palpitations, or blurry vision. His labs were significant for leukocytosis of 22.3, hemoglobin of 18.9, sodium of 131, chloride of 87, bicarbonate of 20, BUN of 27, creatinine of 1.2 with an unknown baseline, glucose of 465, anion gap of 24, beta-hydroxybutyrate of 4.6, A1C of 13.7, and a troponin of 0.078. His urine drug screen was positive for opiates, benzodiazepine, and THC. His electrocardiogram displayed biphasic T waves in leads V2 and V3, and his venous blood gas showed 745, 33, and 31 with a delta delta of 3. Given ECG findings, patient was emergently taken to cardiac catheterization for suspected Wellen syndrome after stabilization with aspirin, heparin drip, beta blocker, statin, fluids, IV insulin, and IV PPI. His cardiac catheterization showed severe multivessel disease, including proximal to mid 70 to 80%, uh, a proximal to mid LAD lesion, a proximal 80% stenosis of the first diagonal branch, and occluded first obtuse marginal branch of the left circumflex with good left-to-left collaterals, proximal 50% stenosis of the right circumflex artery, bilateral femoral artery occlusion, posterior descending artery with 60% mid-segment stenosis, and ejection fraction of 40% with high lateral akinesis on left ventriculogram. Given multivessel disease, the patient was um, sent for cabbage. So post-cardiac catheterization, he was admitted to the intensive care unit for management of diabetic ketoacidosis, upper GI bleed, and hemodynamic monitoring. His DKA resolved by hospital day 2 with typical DKA protocol involving IV insulin, fluids, and electrolyte replacement. Esophagogastroduodenoscopy on hospital day 4 revealed Mallory-Weiss tears resulting in placement of prophylactic hemoclips. On hospital day 9, the patient had cabbage times 2 with left internal mammary artery to the LAD and saphenous vein graft to the obtuse marginal without any complications. He was discharged on postoperative day 5 for outpatient follow-up, and he was sent home on aspirin, atorvastatin, and metoprolol tartrate for coronary artery disease, pantoprazole for GI prophylaxis, and a subcutaneous insulin regimen for diabetes. He was extensively counseled on tobacco cessation, diabetic nutrition, medication compliance, and the importance of outpatient follow-up. So here we can see our EKG, which I showed you earlier, and we can see our biphasic T waves in figure 1 in leads V2 and V3. This is evident of Wellen syndrome. In figure 2, we have a RAO caudal view of a cardiac catheterization. We have the left main coming over here, splitting off into the left circumflex and the left anterior descending, and we can see a fairly significant stenosis here in the left anterior descending artery, evidenced by the arrow. Off of the left circumflex, there is an obtuse marginal branch that should be coming like this, and we see that it is fairly occluded. And if this was a live cardiac catheterization, we would probably see some retrograde filling due to left-to-left collaterals. Here on transthoracic echocardiogram, we can see lateral akinesis as evidenced by the arrow. So this case reflects the complex management of a patient with multiple life-threatening comorbidities. This was further complicated by multivessel disease requiring cabbage and inability to obtain growing access due to bilateral femoral artery occlusions. It is important to note the metabolic derangements seen in this patient because even though he wasn't DKA, his VBG showed a normal pH, which was offset by a concomitant metabolic alkalosis from emesis. Thus, checking the ketone levels, anion gap, glucose, and delta delta were key. His Mallory-Weiss tears were most likely due to a consequence of retching from the DKA and made the case even more complicated as he had to postpone his TEE prior to cabbage. It is unclear if the DKA led to Wellen syndrome or vice versa. However, several mechanisms have been proposed for the interplay between the two, including increase in supply-demand mismatch, leading to myocardial injury, increased free fatty acids in ketone bodies, leading to decreased glucose uptake by cardiac myocytes, and/or acidosis causing increased intracellular calcium and stunning of the myocardium. Thank you.